Dear students, today we are going to discuss the next glomerular disease and which we call IgA nephropathy. In previous lectures, we have discussed the minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy. So today we are going to discuss about the IgA nephropathy. IgA nephropathy is the most common cause of the glomerular disease, and IgA nephropathy is basically most common in Asians and North Europeans. If we talk about the classification of the IgA nephropathy is basically classified into two categories. One is called the primary IgA nephropathy and the second is called the secondary IgA nephropathy. Primary IgA nephropathy is called because the cause is the primary, means the cause is in the glomerulus or in kidney, and the secondary is called because the cause of the IgA nephropathy is because of some other systemic diseases. If we talk about the brief pathogenesis of the primary IgA nephropathy, primary IgA nephropathy is basically responsible for the deposition of the galactose deficient IgA1 in the mesangium. And how they are deposited? Basically, what happens in IgA nephropathy, these galactose deficient IgA1 are considered antigen. Antibodies are formed against these antigens, and these immunocomplexes are deposited in the mesangium. So, this galactose deficient IgA1 are basically responsible for the formation of these immunocomplexes, and immunocomplexes are deposited in the mesangium. And this galactose deficient IgA1 is a heritable trait. Galactose deficient IgA1 is a heritable trait. But this is seen that some subclinical IgA deposition in the mesangium are also seen in some Japanese population. In some Japanese population, what we see in the mesangium, there is the deposition of the IgA. So, this is the primary cause of the IgA nephropathy. The IgA nephropathy, the primary cause is basically the galactose deficient IgA1 in most of the cases. Immunocomplex formation and deposition of these immunocomplexes in the mesangium. So, this is the primary cause. Now, what are the secondary causes of the IgA nephropathy? The secondary causes of the IgA nephropathy may be because of the liver diseases. In liver diseases, basically what happens, there is decreased clearance of the IgA. Because liver is responsible for the clearance of the IgA. So, if there is no clearance of the IgA, so they will deposit in the mesangium. Another cause may be the HIV. Another cause may be the ankylosing spondylitis. Another cause may be the celiac disease. And another cause may be the inflammatory bowel disease. So these are the some causes which are responsible for the secondary IgA nephropathy. And IgA nephropathy may be because of decreased clearance of the IgA or maybe the increased production of the IgA. So we are discussing the IgA nephropathy, and in the discussion of the IgA nephropathy, we have discussed the primary cause of the IgA nephropathy and we have discussed the secondary cause of the IgA nephropathy. The primary cause of the IgA nephropathy, we have discussed the immunocomplex formation in the mesangium because of the galactose deficient IgA1, and there may be the IgA nephropathy because of this deposition. In secondary causes, the secondary causes of the IgA nephropathy, there is the liver disease. Liver diseases, there may be the celiac disease, there may be the inflammatory bowel disease, there may be the ankylosing spondylitis, there may be some patients who have HIV. So these are the secondary causes. What about the clinical features? If we discuss about the clinical features, The patient of the IgA nephropathy usually present with hematuria, and hematuria may be the microscopic or macroscopic. There may be the gross hematuria, and this hematuria may be associated with the hypertension and with proteinuria. Proteinuria is usually subnephrotic. And the nephrotic range proteinuria is very less common. So we are discussing the clinical feature of the IgA nephropathy, and the IgA nephropathy may present with the hematuria. Hematuria may be the microscopic or macroscopic, and may be associated with subnephrotic range proteinuria, may be associated with hypertension. The second presentation may be the acute kidney injury. In IgA nephropathy, there may be the AKI, but the AKI is basically not because of this disease. The AKI may be because of the pigment nephropathy at the time of gross hematuria. So if there is a AKI at the time when the patient presented with gross hematuria, may be because of the pigment nephropathy. And if hematuria resolves and AKI does not resolve, then we should go for the biopsy to check the cause of the AKI, may be some other causes, or to rule out the disease prognosis or progression, or what is the cause of the AKI. So if we talk about the clinical feature, in clinical feature, the patient of the IgA nephropathy usually present with a hematuria, maybe microscopic, maybe macroscopic, may present with a hypertension, may present with the subnephrotic range proteinuria, may rarely present with the nephrotic range proteinuria, and may present with the AKI. But beside this, if you see the complements are usually normal in IgA nephropathy. And when we talk about the gross hematuria is usually precipitated with the upper respiratory tract infection. There may be some kind of upper respiratory tract infection which can lead to these gross hematuria episodes in IgA nephropathy. So this is brief about the clinical features of the IgA nephropathy. Now, how the IgA nephropathy is diagnosed? The IgA nephropathy, the gold standard of diagnosing the IgA nephropathy is the kidney biopsy. And we do the kidney biopsy. If the GFR is decreasing, there is new onset of the hypertension, and the proteinuria is between 0.5 to 1 gram, then we are supposed to go for the renal biopsy. So renal biopsy is the gold standard. And what we find in the renal biopsy, we usually found the mesangial deposit of the immunoglobulin A, especially immunoglobulin A1, IgA1. Usually, when we talk about the biopsy and when we talk about the prognosis, so on the basis of the biopsy findings, we usually see the Oxford classification of the immunoglobulin A nephropathy. What is the Oxford classification of the immunoglobulin A nephropathy? The Oxford classification of the IgA nephropathy is dependent on the biopsy finding, and which we see in the form of number 1, mesangial hypercellularity, number 2, endocapillary proliferation, segmental glomerulosclerosis, tubulointestinal fibrosis, and the crescent formation. This is called the MEST-C. So when we do the biopsy, and on the basis of this classification, the Oxford classification of the IgA nephropathy, we usually see the MEST and we prognosticate the patient accordingly. So this MEST-C is usually we use for the prognosis of the IgA nephropathy. Now, what is the classification? What is the treatment? What is the treatment of IgA nephropathy? So we have discussed the IgA nephropathy classification, primary and secondary. We have discussed the causes of the primary IgA nephropathy, the causes of the secondary IgA nephropathy. We have discussed the clinical features. We have discussed the investigation. We have discussed now we are going to discuss about the disease variants. When we talk about the disease variants of the IgA nephropathy may be associated with the minimal change disease. The IgA nephropathy may be associated with ANCA vasculitis, and IgA nephropathy may be associated with the infection-related glomerular nephritis. So, if we are treating the patient of IgA nephropathy, so we are supposed to see some disease association of the IgA nephropathy. And the disease may be associated with the minimal change disease, may be associated with the ANCA vasculitis, and may be associated with the infection-related GN or glomerular nephritis. So, after ruling out this disease association, we are supposed to treat the patient of the IgA nephropathy. What is the treatment? The treatment is usually conservative. And when we talk about the conservative treatment, we usually give the ACE inhibitors, ARBs, and some associated clinical features are, for example, if some associated symptoms or some associated disease are then we are supposed to treat accordingly. For example, if there is a hypertension, if there is proteinuria, if there is some kind of abnormalities, then we are supposed to treat accordingly. So we usually give ACE inhibitors or ARBs, and the patients who do not achieve proteinuria with these ACE inhibitors or ARBs are usually not achieving the proteinuria less than 1 gram per day, not achieving proteinuria less than 1 gram per day, and the GFR is more than 50, then we are supposed to give the corticosteroids. Our treatment is the corticosteroids if the patient is not achieving the proteinuria, if the patient is not achieving the proteinuria less than 1 gram per day, if there is GFR is more than 50, then we are supposed to give the corticosteroids. But in case of IgA nephropathy, if it is associated with the rapidly progressive renal failure, and if it is associated with the crescent formation, then we are supposed to give the immunosuppression. And the immunosuppression is the cyclophosphamide. We usually give. Besides this, some other treatment studies are also there. For example, the fish oil. But fish oil has inconsistent role. But if we talk about the tonsillectomy has some improved outcome. So tonsillectomy has some improved outcome, but the fish oil has some inconsistent role, but usually are not advocated. MMF and rituximab has no any significant benefit in the treatment of IgA nephropathy. When we discuss about the immunosuppression, in regard to the immunosuppression, there are the two important RCTs.